Left anterior fascicular block is quite common. In a single day OPD, I see 2 to 3 cases of left anterior fascicular block pattern of ECG. And if only anterior fascicle is blocked, patient may not be symptomatic because posterior fascicle is intact, right bundle branch is intact. Those helps to conduct electricity. But if left anterior fascicle block and right bundle branch both are blocked, then patient might develop symptoms like dizziness, lightheadedness, presyncope, syncope. And if symptomatic, patients require permanent pacemaker. But if asymptomatic, you have to monitor it, because bifascicular block can go into complete heart block, because 2 out of 3 conductive tract, 2 are blocked. Just only 1 tract, left posterior fascicle, is depolarizing whole ventricle. So there is chance that this patient can develop symptoms, so we have to monitor it. And if patient gives episodic lightheadedness history, then you have to do 24-hour Holter monitoring and see whether this bifascicular block is intermittently going into complete heart block or not. If yes, then patient requires permanent pacemaker implantation. So what are the ECG patterns you look for to identify bifascicular block? So if left anterior fascicle is blocked, then in inferior leads 2-3 AVF, what patterns will you see? You will see predominantly negative current, like there is a small R wave and deep S wave. So predominantly negative current is in 2-3 AVF, and in 1 AVL lead there will be predominant positive current. It is opposite to 2-3 AVF. So there is a small Q wave and big R wave in 1 AVL. So this suggests left anterior fascicle block. And in addition to that, if there is right axis deviation, that suggests left anterior fascicle block plus right bundle branch block. And apart from that, you have to look QRS width, because if both fascicle is blocked, both fascicle means right bundle branch and anterior fascicle, then QRS will be wide, because there will be lot of interventricular conduction from myocytes to myocytes. So QRS will be more than 120 millisecond, and the deflection of R wave will be more than 45 millisecond. So it will be more than 1.5 a small box. So one small box is 40 millisecond. So if the deflection of R wave is occurring more than 45 millisecond after Q wave, then it suggests there is conduction delay, right? So these are the features that you look for bifascicular block. One is QRS, another is how long it is taking for R wave to peak more than 45 millisecond, and a small R and big S pattern in 2-3 AVF, and the Q and big R wave pattern in 1 AVL. You do not need to memorize this, you just need to imagine heart in 3D. So you might have seen anatomical model of heart in 3 dimension. So if you just imagine the heart in its normal anatomical location, then you can mentally imagine why there is predominantly negative depolarization or negative vector in 2,3 AVF, and why predominantly positive vector in 1 and AVL. So if the left anterior fascicle is blocked, so left anterior fascicle travels anteriorly, right, and left posterior fascicle goes to the posterior wall of the left ventricle. So let's imagine left anterior fascicle that is supplying the current in the anterior and lateral wall of the left ventricle is blocked. So this anterior fascicle is blocked. Now current is going in only posterior fascicle. So current goes to the posterior fascicle and it depolarizes the posterior wall of the left ventricle. And now anterior wall also needs to be depolarized, but anterior fascicle is blocked. So current will again start spreading from posterior wall to anterior wall in this direction. So you know, majority of the ventricular muscle is in the posterior wall, right? Majority of the, if you calculate the grams of ventricular muscle in the posterior wall and anterior wall, majority of the mass of left ventricle is in posterior wall. That's why posterior fascicle is also supplied by collaterals from posterior descending artery. And you won't often see left posterior fascicle block. I have never seen a case of left posterior fascicle block. I have seen many cases of anterior fascicle block and bifascicular block, but till now I have never seen a case of left posterior fascicle block, because it has dual blood supply from posterior descending artery and anterior descending artery as well, left anterior descending artery. So even if one is blocked, another is supplying. This is the design of nature, right? Because if the left posterior fascicle is blocked, then large part of ventricle depolarization will be affected. That's why nature has designed it in that way, I think. So I was talking that left ventricular posterior wall has more muscles compared to anterior and lateral wall, right? So current first of all depolarizes, the electricity depolarizes the myocytes first of all the posterior wall, and then current starts spreading to the anterior and lateral wall. So current is now coming like this way. So the net vector is in this way. So this is the left axis deviation. That's why in left anterior fascicle block there is left axis deviation. So if current is going in this direction, so in inferior leads there will be predominant negative leads, right? Because the net vector is in this direction, right? And here you have AVL lead, here you have lead 1. So in this direction there will be predominantly positive wave. So there will be a small Q and big R wave in one AVL, but there will be predominant S wave in the 2,3 AVF. I will continue this video in another part.